Good morning. This is Dr. Rizer. I'll be providing you with the information covering Module 11, which is the assessment of pain. And this information covers Chapter 7 in the Seidel text and can be supplemented with your Seller text in Chapter 3. And now the Seller text also refers to the assessment of pain in a lot of the other chapters. Of course, that's over each particular system. So be sure to just pay attention to that as you are going through some of the other modules as to how you would include pain in your assessment of all other body systems. Let's see here. Now, pain, let me go back. Pain is a common, uncomfortable sensation and emotional experience associated with actual or potential tissue damage. That's the textbook definition. Acute pain is, of course, sudden and of short duration and is usually associated with surgery or injury or an acute illness. Chronic pain is persistent and lasting weeks, maybe even months or years, and is usually associated with some kind of a prolonged disease process. Persons that have individual responses, or persons do have individual responses to pain because it's a physiologic, behavioral, and emotional phenomenon. The threshold at which pain is perceived as well as tolerated, of course, varies among individuals as well. The Joint Commission requires that pain be assessed and documented at an initial assessment and repeated with each subsequent assessment. Pain should be recorded according to the intensity, and it should be treated promptly. Be sure to go to your Evolve website and view the media link to reinforce your learning regarding the physical exam, the H&P, the checklists, and there's many other tools there that can aid you in learning about advanced physical assessment. Now, when the chief complaint is pain, the location and related symptoms may assist in the diagnosis of a patient's condition. If the pain is related to a diagnosed condition, such as surgery, trauma, or cancer, assessment of its character and intensity is necessary in order to achieve pain control. So we should always remember that there may be more than one cause of pain. The subjective report of pain is the most reliable indicator of pain and should be believed even when observed behaviors do not seem to correspond. We should encourage our patients to report the presence, intensity, and character of the discomfort that they are experiencing. I had an aunt who had surgery and went to the recovery room, and unfortunately she had a nurse who did not do these accurate pain assessments for her. She complained of being short of breath, and this was causing her great anxiety as well as having some pain. And this nurse told her, "Oh, you're not hurting that much. You're breathing fine. Your pulse ox is 100%, and you just had a small surgery. You don't have that kind of pain." And it so frightened my aunt to feel alone and feel like she had no recourse, no help, no one was listening to her, that she was afraid the rest of her life to have surgery, even to go to the doctor. So that one experience influenced her lifetime of health care. Now, there are several methods that we can utilize for reporting and measuring a patient's pain, including that self-report pain rating scale, the assessment of pain behaviors, and for infants and children, we also have pain scales that we can use. And we'll talk about those a little later in the lecture. We'll begin our discussion by providing a brief overview of the anatomy and physiology of pain. Pain is referred to as the fifth vital sign because it's often associated with tissue damage. It has a pathophysiologic effect on body systems, and the patient's emotional response may increase the pain perceived, just as my aunt experienced. Acute pain is sudden and of short duration, as we've said, and is often associated with the surgery or injury or illness. The chronic pain could last for much longer and is usually associated with disease. But as we've said, more than one cause of pain can exist in the patient simultaneously. Nociceptors transmit pain impulses from the periphery along A delta and C fibers to the dorsal horn of the spinal cord in the brain. Now, the larger A delta fibers carry sharp, well-localized pain, while the smaller, unmyelinated C polymodal fibers carry duller, more diffuse pain, which is more slowly transmitted and tends to be chronic in nature. Certain biochemical mediators are produced in response to tissue damage and help move the pain impulse from the pain receptor to the dorsal horn of the spinal cord along lateral spinothalamic, reticulospinal, and spino-mesoencephalic nerve pathways to the brain, where pain is perceived. These biochemical mediators include bradykinin, prostaglandin, leukotrienes, serotonin, histamine, catecholamines, and substance P. Peripheral pain receptors transmit sensation to the dorsal horn of the spinal cord through sensory nerve fibers. And as we've noted before, these sensory fibers are specialized for either rapidly transmitted, sharp, well-localized pain, or for more slowly transmitted, dull, burning, or diffusely localized pain. If the pain sensation is not blocked by physiologically produced interceptors, such as opioids or some kind of nerve stimulator, it's relayed on from the spinal cord to the brain through the spinal tract nerve pathways. Now, emotions, culture, cultural background, sleep deprivation, other experiences with pain that the patient has had, and patient age. These are all factors that have an impact on the perception and the interpretation of pain. After sensory information reaches the dorsal horn of the spinal cord, there's a two-way control of nociceptive transmission within the spinal tracts so that the pain signal can be modified depending on the presence of other stimuli from either the brain or the periphery. Along the nerve conduction pathways, there are gates that control the number of impulses sent to the brain. Non-pain impulses, such as those produced by ice or massage, can compete with those pain impulses for transmission along the spinal tracts to the brain and alter that perception of pain. This figure is on page 141 of your text, and these page numbers may be slightly different depending on the version of the text that you have. This picture depicts the transmission of pain impulses from pain receptors to the central nervous system. Now, note that when the person steps on the painful stimulus, as over there on the right side, you see the person's foot stepping on the painful stimulus, the pain receptors transmit the pain impulse from the periphery along A delta and C fibers to the dorsal horn of the spinal cord, then along anterolateral spinal thalamic tracts to the brain, where it is perceived as pain. And as we've noted in the previous slide, an individual responses to pain vary widely, as does the individual's threshold of response and tolerance levels to pain. Response to pain is a physiologic, behavioral, and emotional phenomenon, as we said. And several of these factors, of course, have an impact on the perception and the interpretation of that pain. Neonates feel pain. The nervous system is adequately developed for pain perception early in fetal life. Some differences in the nociceptive processes by infants are due to neurophysiologic and cognitive immaturity. Newborns are less able to modify pain impulses, and thus preterm and full-term newborns may be more sensitive to pain stimuli than older infants and children. Pregnant women experience pain in several ways through the course of the pregnancy. Lax ligaments, weight gain, hyperlordosis, and anterior tilt of the pelvis can all cause back pain. Cramping or pressure pain may be caused by premature labor or from Braxton Hicks contractions, or the pressure sensations may simply be due to the gravid uterus, which can also manifest as epigastric pain. The round ligament may be painfully stretched, and there may be pressure on the bladder by the weight of the enlarging uterus. During labor, pain may be related to cervical dilation, stretching of the lower uterine segment, pressure on adjacent structures, and cellular hypoxia during contractions. During delivery, pressure from the fetal head against the pelvic floor, vagina, and perineum causes additional pain. There's no evidence to suggest that older adults have a diminished perception of pain. However, as a group, older adults may not report pain for a variety of reasons. They may believe that it's simply a normal part of aging, and they may not want to be a bother. They may feel that if they report their pain, it would only lead to costly tests or even hospitalization, and oftentimes, they're hesitant to take pain medicine. When we review the related history of the present illness, it's important to consider the patient response to questions about each topic in order to assess the patient condition and elicit clues for focusing the physical exam. So during your practice of the physical exam, be sure you pay attention to what the patient says. Don't just go through your rotely memorized steps. By paying attention to what the patient says, you may have to go a completely different direction for a considerable time to elicit more information about the actual physical condition. When considering the present problem, there are several aspects of pain that should be considered during the patient evaluation. These include the onset, quality, intensity, location, associated symptoms, what the patient thinks is causing the pain, its effect on the activities of daily living, and the patient's psyche. What controls or relieves the pain, if anything, and what medications is the patient taking for it. Questions concerning the onset of pain should include the date when the pain started. Was it sudden or gradual? What time of day was it? How long did the pain last? Are there any precipitating factors? Is there any variation in the pain, a rhythm to it? Is it constant or intermittent? The quality of the pain refers to describing terms like throbbing, shooting, stabbing, sharp, cramping, gnawing, hot or burning, aching or heavy. The intensity of pain can be described as slight to severe using a pain scale from 1 to 10, or meaning from very little pain to 10, the worst pain you've ever felt. The location of all sites of pain should be identified. Have the patient point to it. Does it travel or radiate? Are there other associated symptoms like nausea, fatigue, behavior changes, irritability, or distress? What does the patient think is causing the pain? What is the effect of the pain on daily activities? Does it limit them in any way? Is the patient's normal sleep cycle disrupted? Is there a need for increased rest? Is there a change in appetite? Many of you have learned the mnemonic old carts for remembering the components of assessing the attributes of a symptom. And it might be helpful here too to memorize and practice as you elicit information from your patients about their pain. This slide shows what each letter stands for. O for the onset of the pain, L for the location, where is it on the patient's body, D the duration, C the character, A the aggravating or alleviating factors, R the radiating pattern, T is the timing, and S is severity. So remember this acronym, old carts. Does the pain have an effect on the patient's mood or social interactions? Does the pain make it difficult to concentrate? What kind of pain control measures has the patient already tried? And what effect have they had, if any? What medications does the patient take? What medications have they tried in the past? What effect do they have on the pain? And we should also talk with the patient about his or her personal and social history regarding the impact of pain. What are their previous experiences with pain? How have they coped in the past? What kinds of strategies have worked for them in the past? Discuss family concerns and cultural beliefs about pain. In my practice, I see so many family dynamics in the labor and delivery suites concerning pain control. I've seen underage patients deliver a child without an epidural because their parents feel that they should be punished, in a sense, for getting pregnant out of wedlock or at such a young age. There are also cultural beliefs that demand the father or leader of the family decide what should be done in spite of what the patient might think or feel. So you have to take all of these things into consideration in order to make a plan for the patient, but also to even make an accurate assessment of the patient's pain. With children, we need to speak to their level and recognize their language for pain words. By asking, "What do you tell your mother or father when you're hurt?" might elicit more specific information from the child concerning how he communicates about pain. Also, noting facial expressions, grimacing, and protective posturing are all indications that could be noted by the parent in the past and may be helpful in identifying the extent of pain in younger patients. And as we've said in a previous slide, during pregnancy, pain is mainly associated with the increasing fetal size. With older adults, we should investigate all known medical conditions and physical limitations to identify potential sources for persistent or acute pain. What are the words used by the older adult for pain, such as achy, sore, or discomfort? When the older adult is cognitively impaired, have a family member or caregiver describe known cues to the patient's expression of pain. When the chief complaint is pain, the location and related symptoms may assist in the diagnosis of the condition. And if the pain is related to a certain condition that you can visibly see, such as trauma or surgery or cancer, you should assess its character and intensity in order to achieve adequate pain control. And of course, again, remember there may be more than one cause of pain. Because of the subjective nature of pain, assessment is often based on history and the patient responses to various tools that evaluate pain intensity and quality. The subjective report of pain is the most reliable indicator that pain exists and should be believed, even when we observe other behaviors which may not correspond to an indication of pain. Several pain rating scales have been developed. Some examples of these are in your textbook on page 144. And it's important to remember that the patient's rating of pain may not compare with the pain rating of another individual, or even for an equivalent injury or condition, as in my aunt's case. The patient's rating should be the gold standard for that patient for future comparison after pain treatment. And as I used my aunt's experience in the recovery room as an example earlier, I'll go back to that again. That nurse disregarded my aunt's request for pain medication. She told her, "You only had minor surgery, you're not hurting that bad." And this experience led to a lifelong fear that she might not be given adequate pain medicine. She didn't even want to go to the hospital. Consistent use of a particular scale will contribute a lot to consistent interpretation of pain. Many hospitals and other agency groups utilize a specific scale so that more consistent interpretations of patient ratings will more likely occur across providers. Also, when introducing the patient to a pain scale, provide clear explanations about the purpose of the scale and the meanings of the numbers or figures on the scale. We should learn the patient's customary terminology for different kinds of pain, such as aching, stabbing, or burning, and practice the use of the pain scale with a patient's past painful episode, such as a headache or specific injury, before evaluating the current pain level. Remember that the patient may have multiple pain sites, and the pain rating may vary with each site, and we should document the pain rating for each site of pain. Pain intensity may vary with routine activities such as moving or coughing. We should link pain intensity reported with the location and the activity. And we should, of course, reassess regularly, even after the problem is resolved. This is figure 7-4 in your CITEL text, and it shows the visual analog scale, which uses a 10-centimeter line with word anchors on each end. On the left is no pain, and on the right is worst pain. Ask the patient to mark the level of pain felt on the line between no pain and worst pain. Mark and document the patient's rating by using a centimeter ruler to identify a numeric pain rating for future comparison. Figure 7-2, that next figure there, shows a descriptive pain intensity scale, describing pain as slight, mild, moderate, severe, and worst pain. And the patient should mark his level of pain on this scale as well, and it can be compared to future assessments of pain. And the last scale there, 7-3, shows the numeric pain intensity scale, which is utilized in many hospitals across particularly this region. And the painometer is a multidimensional measure of pain, allowing a measure of intensity and quality and an opportunity for localization of pain. It's the first handheld instrument that meets the standards of the Joint Commission. This is an example of the FLACC Behavioral Pain Assessment Scale for Nonverbal Children. FLACC is an acronym for the 5 assessment categories: face, legs, activity, cry, and consolability. This scale is used most commonly to assess acute pain with surgery in children between 2 months and 7 years of age. Dementia may complicate the pain assessment of older adults. Many patients with mild or moderate cognitive impairment are able to report pain reliably with a simple pain rating scale, and many can describe their pain when asked. And when a self-reporting scale cannot be used, we should observe for pain behaviors, especially when a pathologic condition is present that could cause pain. One tool is the checklist of nonverbal pain indicators, which provides guidelines for consistent observations of pain behavior. However, a pain intensity rating is not calculated. A trial of analgesia may help confirm that the observed behaviors are related to pain. And throughout your examination of the patient, be alert to behavioral signs of pain such as guarding, distorted posture, reluctance to be moved, a facial mask of pain including lackluster eyes, wrinkled forehead, a sad or frightened look. Vocalizations such as groaning, crying, or quietness can indicate pain. Body movements such as head rocking, pacing, or an inability to keep still. Also included in our assessment of pain behaviors are changes in vital signs, a pallor or a diaphoresis, pupil dilation, dry mouth, decreased attention span, and greater confusion. These are some classic pain patterns that may alert you to underlying conditions. Bone and tissue pain tends to be tender, deep, and aching. A heavy, throbbing pain could be associated with a tumor pressing on a body cavity. A burning, shock-like pain might indicate nerve damage. The classic clenched fist over the chest with diaphoresis and grimacing is typical of, you guessed it, MI. Cramps or spasms could indicate visceral pain. The Premature Infant Pain Profile, PIPP, uses gestational age, behavioral state, heart rate, oxygenation status, or oxygen saturation, brow bulge, eye squeeze, and nasolabial furrow to assess procedural pain in preterm and full-term neonates between 28 and 40 weeks. The neonatal infant pain scale uses facial expression, cry, breathing pattern, arms, legs, and state of arousal to assess preterm and full-term infant procedural pain. The neonatal infant pain scale uses facial expression, cry, breathing pattern, arms, legs, and state of arousal to assess preterm and full-term infant procedural pain. No, I'm sorry, I just read that. This is the CRIES scale. The CRIES, C-R-I-E-S scale, uses crying, oxygen saturation, heart rate, blood pressure, expression, and sleeplessness to assess procedure and surgical pain in newborns and infants. Now note that physiologic measures and behaviors are combined for the development of the pain behavior scale that is not designed to rate pain intensity. A pain behavior score helps identify the presence of pain and can be used to evaluate pain management efforts. Some children as young as 3 can have adequate communication skills to report their own pain perception. So we should assess the child's ability to use a self-report pain scale by determining if the child understands concepts of higher and lower, more or less. Give the child a chance to practice using the chosen pain scale by describing a prior painful episode such as a finger stick or an earache. Valid and reliable self-rating pain scales for young children include the Wong-Baker Faces Rating Scale and the Ucher Scale. The child should be given clear instructions about the amount of pain each face means, beginning with the face with no pain or hurt and ending with the last face that is the most pain or hurt ever felt. The child should select the face that is closest to the amount of pain he's feeling right now. Do not, however, compare the child's own facial expression to that on the scale to evaluate the child's pain. Older children can use these pain scales as well as those listed for adults. And this is a picture of the Wong-Baker Faces Rating Scale. And we should explain to the patient that each face is for a person who feels happy because he has no pain, or sad because he has some or a lot of pain. Face 0 is very happy because the person doesn't hurt at all. Face 1 hurts just a little bit. Face 2 hurts a little bit more. Face 3 a little more, and face 4 a whole lot. Face 5 hurts as much as you can imagine, although you don't have to be crying to feel this bad. We should ask the patient to choose the face that best describes how he or she is feeling at that moment. This scale is recommended for patients 3 years and older. The chart A on the left is a version of the Ucher scale for white children. B is for blacks and C is for Hispanics. And we're back again to pregnant women, and the process of labor involves significant pain and stress for the majority of women. And laboring women may describe their pain as sharp, cramping, aching, throbbing, stabbing, shooting, heavy, and exhaustive. Some women describe their pain as more severe than that of patients with cancer. Childbirth training does not result in significantly different perceptions of pain, however, and socioeconomic status and prior menstrual difficulties may be better predictors of pain severity. Self-reporting pain scales can also be used with older adults, and we should ensure, though, that the patient can hear and understand the instructions for the use of the scale, and repeat the instructions if necessary. If the patient has visual problems, provide a scale with large printing and give verbal descriptors for the self-report pain scale. Touch or point to the body part when asking about the patient's current pain to help focus the older adult and clarify where the pain is located and which pain we're talking about. Dementia may complicate the assessment, as we noted before, so use of the checklist of nonverbal pain indicators could be necessary for these older adults as well. Neuropathic pain is a form of chronic pain caused by a primary lesion or dysfunction of the central nervous system that persists beyond that time expected after healing. Potential causes include post-therapeutic neuralgia, diabetic peripheral neuropathies, trigeminal neuralgia, or radiculopathy. Damaged peripheral nerves repetitively fire nerve fibers, leading to hyperexcitability of the dorsal horn neurons. The hyperexcitability transmits enhanced pain signals to the brain, causing sustained pain. The pain may be described as burning, shooting, stabbing, or shock-like. Pain sensations may worsen at night, and there may be exaggerated pain responses to painful stimuli. Even though pain sensations may be exaggerated, such as a pain response to light stroking of the skin, a light touch, a pinprick, a vibratory sense, and proprioception may be diminished in affected areas, resulting in numbness or weakness or loss of deep tendon reflexes in these areas. The presence of regional pain beyond the site of specific nerve injury with motor, sensory, and autonomic changes following a predominantly traumatic noxious event, with or without specific nerve injury, is descriptive of complex regional pain syndrome. This phenomenon is believed to be caused by the chronic release of neuropeptides leading to neurogenic inflammation. The neuropeptide release may facilitate nociceptive sensitization and contribute to motor disturbances. There may be deep pain at rest, with burning, shooting, or aching character, an exaggerated sensitivity to cold, hyperalgesia to pinprick or other touch, allodynia, or pain symptoms to stimuli that aren't typically painful, such as when you put a EKG patch on someone's side and they just about jump out of the bed. It may be cold, but that would be a hypersensitive reaction to that cold sensation. There may also be weakness or restricted range of movement, exaggerated deep tendon reflexes on the affected side, muscle atrophy, and contractions may occur. There may be abnormal skin color, red or hot in the early stages, and cyanotic and cold in later stages. As in my aunt's case, her fear of pain might never have happened had that nurse in the recovery room so many years ago been appropriately skilled in her assessment of pain. One way to keep well is to be freed of the prospect of pain. As a chapter overview, when assessing the patient presenting with pain, we should include all of these elements. As part of this focused assessment, we should first ask the patient if they're currently experiencing any pain, then assess the components of that pain, including its onset, quality, intensity, precipitating factors, location, effect on activities of daily living, its effect on the psyche, what pain control measures have been utilized, and what medications have been used. Then utilize one of the pain scales to quantify the pain, differentiate between acute and chronic pain, and also be sure to assess behavior patterns for pain, as well as observing for classic pain patterns. This concludes Module 11, Assessment of Pain. Thank you for your attention.